Hi, everyone. Thank you so much for being here with us today. We are so excited to just take a step back and have this intense and excellent conversation about cultural competency in healthcare, ensuring equal access. So thank you for joining us. Today, we have some experts on the call. We have Debbie and we have Zoraida. And if you guys could just quickly take a moment to introduce yourselves, that'd be great.
Sure. I'll start. I'm Debbie Lesser. I am the Director of Language Access Services for a large healthcare system in Atlanta, Georgia. I also am a sign language interpreter by trade. And I serve as the treasurer for the National Council on Interpreting in Healthcare.
Thank you.
Good morning, everybody. My name is Zoraida. I'm a nurse by background. That's my training. Approximately close to 27 years I've been in nursing. And currently I'm a director of a local healthcare organization here in Phoenix, Arizona.
Awesome. Thank you guys so much for being here with us today. I really look forward to our conversation. My name is Liz, and I work with Effectiff as the language access expert. So without further ado, let's go ahead and dig in. So our first question, how do healthcare institutions measure the success of their language access programs? Are there specific metrics that they should be focusing on? What are your thoughts?
Sure. Debbie, I'll take this if you don't mind real quick.
Sure. Yeah.
So there's not a specific metric to my knowledge regarding like language access, but we do pay attention to our patient satisfaction scores. Readmission rate would be another indicator, another metric to let us know how well we're doing providing that, that access and that interpretation to our patients.
Absolutely. Yeah, that's definitely something that you hear about is that recidivism. Are they coming back? Are their problems getting worse? Are these new problems? And that is absolutely something that can be a very clear indicator that communication is not happening or it is happening, depending.
Right. Mm-hmm. Correct.
Yeah.
Debbie,
I would add, yeah, definitely. I would add to that. Obviously, patient compliance with discharge instructions, a lot of that has to do with being able to provide that information in the patient's preferred language. And not just, I think a big frustration for a lot of healthcare systems is that like after visit summaries, part of it might be in the patient's language, but not all of it. And so finding a way to partner with an interpreter, for example, to make sure that discharge instructions are clear. One of the things that I tend to encourage, and this it'll be interesting, Zoraida, to see if this is something you that you encourage as well. But regardless of language, a lot of times, like my parents, for example, when they go to their healthcare practitioner, and then they come home and I say, so what did the doctor say? They can't tell me, or they might only remember bits and pieces of it. So, and especially if you happen to be someone who's receiving some intense news about a diagnosis, a lot of times you end up zoning out on what it is that the doctor's saying. So I encourage a lot of patients to record discharge. And, of course, everybody needs to be in agreement with that. The nurse, the doctor, whoever's in the room needs to be in agreement, including the interpreter. If you're using a video interpreter, let the interpreter know we're going to go ahead and just record this. And that way, when the patient gets home, they can review those discharge instructions again with the interpreter. They can hear what the interpreter said. So that I think is kind of a helpful tool to give people. It can be a controversial suggestion. So it depends on, the policy at your healthcare system. But it's another tool in the toolbox.
Absolutely. I totally agree. And that is such a good idea. I think I'm going to talk to my mom about that because she has the same problem. She goes to the doctor, she tells him what's going on, and then she comes home and we have no idea sometimes.
I think what we see more in the hospital rather than recording is we ask who is going to be the caregiver or the care provider when they're at home. Mm-hmm. This is obviously just straight for home discharges. And then if they can't be there, then we FaceTime or we do a video conference. and then they
Perfect.
go through the training. Many times with our families that do want to go home and don't want to go maybe to a skilled nursing facility or prefer because they have so much support at home, even our physical therapists will do family training, and they do it a couple of times prior to discharge. So we make every effort to really provide that training. If they can be in person, obviously with physical therapy, that's vital. But even just wound care, we bring them in and do a subsequent and video training, like just more live.
Mhm.
Best, and then we can answer their questions then.
That's such a
Yeah.
good idea.
Kind of
Some
avoid
people,
the video recording piece that can be tricky.
Yeah.
right,
That's a
right.
good idea.
What some providers I've noticed will do though is they will, if let's say we do get a family member that can participate in some of those instructions, they'll then use that person to interpret. I don't really need an interpreter now because the daughter is here.
Mhm.
And that's where I caution managers, leaders to not do that. We still need the interpreter in the room so that way daughter can be daughter and not have to act as the intermediary when it comes to communication.
Correct. Yeah.
Yeah, absolutely. Absolutely. Thank you guys so much. I love that. Yeah, there's some really good ideas there. Just really quick for the audience, if you guys have questions or comments, obviously pop it in the chat. We're looking forward to hearing from you. Let's move on to our next question. What kind of training do you think is most effective in preparing medical staff to work with interpreters? Something that we hear a lot in our webinars and in these conversations that we're having with experts is that the staff can never know too much about working with language services in general. And how do we make sure that we are giving them the tools that they need to be successful, to be able to, facilitate communication as needed, to bring in the interpreter when they need to know the difference between an employee that has maybe bilingual credentials, but not necessarily an interpreter versus having an interpreter in different situations where things apply. What is the most effective way to prepare them?
You want to go first?
No, go ahead, Debbie.
No, it's okay. Gosh, okay. I think you and I love the fact that you're clinical and I'm not, because I think you and I balance each other out with that. So I'm looking forward to what you have to say about this. The first thing I would tell when I educate clinical teams is interpreters are available from admission to post-discharge. So not only while they're here in the system, but once they've been discharged, if you need to communicate with a patient at home, there's a method to do that, either through a telephone interpreter or usually telephone interpreting. We also, at my healthcare system, we also have a patient interpreter line. So if a patient needs to call back into our system, they can get connected with an interpreter before they call into our system. So that's something to consider if you don't have that set up already. The other thing so other bits of training, we've created a computer-based learning module that is required for all patient-facing team members. So when you're hired at my healthcare system, you have to take this training, and that it provides education. So that way folks know that we're not providing language access simply because it's a good thing to do, the right thing to do, but there's a lot of legal reasons why we need to do this. Whether it's the Americans with Disabilities Act or the ADA for deaf patients, or Title VI, for example, for spoken language patients. That really covers everybody. But there's laws in place and CMS regulations in place that require us to provide language access. So we try to educate clinical team members about that as well. I also there are some changes that recently happened with the Affordable Care Act, Section 1557 specifically, that talks about language access and ensuring that that the folks that are communicating with patients have the proper credentials to do so. So there's a difference between being bilingual and being an interpreter. There's more training. It's kind of like saying, I as I, as a medical interpreter, have worked in this field for, I don't know, 20 years. I work in all aspects of healthcare, not just cardiology or not just, mother baby. I work in all aspects of healthcare. I see nurses all the time give IVs, draw blood, check blood pressure, do triage, all that stuff, which means I'm quite experienced in lots of different specialties. And I know my medical terminology inside and out, pretty much, which means, Zoraida, if you're out sick today, I should be able to substitute for you, right?
Mm-hmm.
No, because I'm not clinical. So it doesn't matter how much exposure I've had. There are things about being a nurse that I just don't have because I'm not a nurse.
Right.
So, and it's the same thing. Just because you're bilingual doesn't mean that you have all the training that goes into being an interpreter. So that's a really, really important aspect that I like to stress to people. And we are at my healthcare system getting ready to implement a qualified bilingual staff program, which will enable bilingual team members to speak directly to patients in their preferred language, which I think is so valuable. It really puts patients at ease. It really ensures really clear communication. But what it doesn't allow you to do is interpret between the patient and someone who doesn't speak their same language.
Yeah. I completely agree. There is that difference, and it's a fine line, right? I have many staff members who are bilingual in Spanish and English, right? Born and raised, have great conversations. And so throughout the day, the care is much easier, getting them up, going to the bathroom, those. But when it comes time to obtaining consent, right? Describing the surgery, the procedure that's going to happen, we absolutely bring in an interpreter, right? That's very different. I've been speaking Spanish most of my life, but I don't remember all the words of all the organs in the body, gallbladder, liver. And I'm like, oh, geez, right? So I'm not the best, but I can give somebody directions in the hospital, right? So that's very easy. To answer the question, though, of what kind of training do I think is most effective in preparing, whether it's medical staff or nurses or anybody in the healthcare system, it really kind of depends probably on the type of interpretive services you have available at your facility. So there's policy that everybody gets at onboarding, right? Knowing the rights of the patients and when they are required to have a qualified interpreter. And then, of course, there is the various kinds. In person, I think people forget that they really should continue to talk to the patient, not speak to the interpreter, right? Not look at the interpreter. But that is something that's practice. So a role-based, scenario training of that sort, just kind of reminding them so that the patient still feels that you as the caregiver are talking to them. I think asking the interpreter, more of a preference. Do you want me to continue speaking and then pause after X amount of time? Some interpreters want it after so many minutes and others are like, no, continue. And then when you're at a natural pause, I'll jump in. Then you have, of course, the Syracom phone. That one's probably the most difficult. We all know that one. It's a little bit cumbersome, but I find it effective, though. It's better than not having an interpreter available. So learning even how to use that phone properly is very helpful. And I know patients and families find it really helpful, right? That becomes the phone at the bedside for the patient, and they really like it. And they'll learn to pick it up themselves. And then oh, they have a question for me. And then the virtual for, again, sign language, I think, again, making sure that the audio and everything is well, right? And everybody can hear, but again, speak to the patient, not to the iPad that's on wheels, and it's just hard to remember to do that. So in person, I think, and role-based is probably the best. And then, of course, just your policies. That's probably the best kind of training. Find out what is available in your organization. What do you normally do? And then make sure people are comfortable using those methodologies.
Mm-hmm. Absolutely. And to add what you guys have said, I think it's really important to have repeated trainings, repeated exposure. Things are changing, vendors change, policies change, equipment changes, but that those core language requirements, they're still going to be fairly general, fairly consistent. Yeah, that's the word. Thank you. And, making sure that we're having those conversations. If it's a conversation, I feel like that is possible, is the best way to make sure that your teams understand, how to get access. I can't tell you how many times I've called an emergency room and said, hey, do you have interpreting services? And they're like, we don't do that. You do. You just aren't sure how or where. And, that's again, something that requires, when you're getting your training as a new hire, you're not thinking about the situations that you're going to be in. And then when you're in those situations, it's like, I don't know what to do.
Yeah.
Things fly, it's in one ear and out the other. There's so much information.
There is. The other thing, if you don't mind, the other thing that is a huge piece of education for medical staff is not, even if someone says, I have my daughter here, she can interpret for me, I don't need one of your interpreters. It's super important to check with your healthcare system to determine what their policies are. But typically, healthcare systems will encourage you to use the professional interpreter that's provided by the system. And the reason is that we don't have any guarantee that the family member, like Zoraida was saying, even though she's bilingual and has been most of her life, she may not know medical terminology in the other language. We also have no guarantee that what is being said is actually being interpreted when you're using a family member or a friend. There are some cultures that when bad news is delivered, it's not shared with the patient. And that's typical of that particular culture or those cultures. So we can't guarantee that what we're communicating is actually being said to the patient. So one of the ways that I advise, a lot of healthcare providers have said, yeah, but what do I do if they're insistent on using their family member? I don't want your professional interpreter. I really want my daughter to interpret for me instead. So what again, this is what we do at our healthcare system. It varies depending on your policies. But one possible workaround is we allow, rather than getting into a power struggle as a clinical team member, rather than getting into a power struggle or creating an unsatisfactory dynamic between the two, what I say is, we'll be happy to use your daughter. However, I'm still going to pull in my professional interpreter. We'll just have the interpreter on in the background. We'll let them, and they'll let us know if anything is omitted or misinterpreted or something like that. And that way we know as clinical team members that we're still covered, that we still are ensured that what we're communicating is being communicated effectively. And that's the key term, effective communication. But then the patient still has that comfort of knowing that, okay, I really prefer to hear it directly from my daughter. So it kind of,
correct.
It's a win-win
It's the
for
same
everybody.
approach, really, if you think about it, and whether it's everybody speaks the same language, if they want their family member there, their daughter, their loved one, to be able to hear that same information, you would do it for them. So if you take that same approach, it's pretty easy. And I find that most families appreciate it. Again, you're not getting into a power struggle. You're just trying to make sure that the information that the physician or that the nurse or whoever it is, the social worker is providing is correct and accurate information. You don't want your patient to think they're going for a small procedure when in fact it's a very large or difficult procedure, right?
Sure.
Absolutely. So in that same manner.
Yeah. Guys, we do have a couple questions that I wanted to pop over to our chat for. Zoraida, specifically to you, can you please repeat the 2 ways that you like to track the success of, you mentioned readmission rates, and what was the other one? This was based on the first question. How do healthcare institutions measure success?
Correct. Patient satisfaction scores. Would likely to recommend, especially that's a big one. And then in the CMS questions, they've changed a couple of them, but there are specific questions like how was discharge instructions, communication over medication, like those key metrics. And then would you likely recommend are really 3 big ones that you would probably pay attention to, that I pay attention to when it comes to the patient experience for our patients that we take care of.
Awesome.
Zoraida, do you have any questions on those patient satisfaction surveys that have anything to do with language access? Does it say, were you offered an interpreter? Were you satisfied with your interpreting services?
You know what? We get them straight from CMS, HCAP. So they would determine that. I do not believe there is an exact question like that.
Yeah, there's not. At least not at our healthcare system. So
we don't add on additional questions.
Yeah. If there was some way that your healthcare system, if you could get creative with that, and feel free to share that. Like, that's a struggle that I have. I really would love to have our non-English speaking patients have one or two additional questions. So we know, did you get an interpreter at starting right from the beginning, or did we wait until discharge to give you interpreting services?
Right.
And were you satisfied with the services that were provided?
Right.
There are sometimes some healthcare systems say we only provide VRI, video remote interpreting, and over the phone interpreting. We don't provide in-person interpreting. And
Mhm.
for some, even for spoken language patients, if you're hard of hearing, or there's a cognitive delay, or there's a psychiatric diagnosis, or there are reasons why video interpreting or telephone interpreting may not be effective. So, so having a question like that would be really helpful.
Mm-hmm. Agreed.
Yeah, it definitely would help to gauge the response to the services that you're providing, is if you get that feedback from those patients.
Right.
Another question that we had that popped up based on the first question is from Katina R. What are the new or updated 1557 credential requirements? You guys mentioned 1557 and some changes there. And can you talk a little bit about the credential requirements?
So those are, I don't have them in front of me that I can pop in the chat, but they are definitely available online. There are some new requirements that have to do with appointing a 1557 coordinator at your healthcare system, making sure your language access plans are updated and include things like non-discrimination procedures, the name of your 1557 coordinator. There's a number of dates and requirements that have been updated. The thing to keep in mind is that we are still required to ensure that communication is effective. That's really the bottom line. So these just tweak how we do it, these updated requirements. So I'm hoping someone can put a link to that in the chat if you have that available.
I'm sure we'll add that. Thank
Great.
you. Anything you wanted to add?
No, I totally agree. I've actually written it down as a note for myself to look them up and make sure that, there isn't anything in there that I need to know. Right. And also then share with my colleagues and coworkers at work.
One thing that, sorry,
if you go to, I'll just go ahead and do a shameless plug here for NCIHC. So if you go to ncihc.org, the National Council on Interpreting in Healthcare, we have some position statements, and there are some webinars on there. If you're a member of NCIHC, there's some webinars that talk about Section 1557. You can also check out CCHI. Their website has some information on there. And then, of course, LinkedIn, or just do a Google search and it'll bring you to some of those links as well.
Yeah, absolutely. Thank you so much. Anything else to add about that?
No, I think somebody took your advice, Debbie, and they put a link in. So thank you.
Oh, great. Perfect. So I do have one follow-up question that I think is very relevant. Again, this one's from Catherine Bell. So when you have those surveys that the patients are completing, they don't have any questions about language access, but when you guys are receiving them, are you getting responses from those non-English speaking patients? Or is it often only the ones that can actually speak English? And then what are you doing to increase the response rate for non-English speaking patient surveys?
And do you provide those surveys in languages other than English?
Let's add that one on there too.
These are great questions. And in full transparency, I'm not the one that typically receives all of them, right? We have a whole patient experience. My understanding, though, I do believe they are sent in their language certain. I don't think we probably have them all, but I believe that is a regulatory ask or requirement. And I don't have the exact numbers from my organization. Really, I don't. So I don't know if our response rate is more or less. That is something that I'd have to take back and look into. So I'm not really able to answer that question.
I understand. No problem. I understand.
I can tell you in my healthcare system, I do believe that the response rate for non-English speaking patients is less than that of English. That said, and a lot of that, it may be, even though they may receive their survey in their preferred language, sometimes it's just access to technology. They may receive it through MyChart, for example, or through an email. Systems have gone more virtual as far as that goes.
Yeah.
And a lot of times our non-English speaking patients don't have access to technology at the same level that English speakers do. So, of course that varies.
Right.
But yeah, that definitely has an impact on response rates.
Very good point. Anything else to add to the question about, measuring success of language access programs?
I will tell you one thing that I did go to my patient. So my language access department is not under patient experience. A lot of times they are. So there's definitely more collaboration and partnership. And not that we're not collaborative, we are. But one, I did ask, can we add questions about interpreting services to our survey, and was told no. That said, what I was told we could do is create a task force. So if we could get, most of our patients are Hispanic. The large majority of our non-English speaking patients are Hispanic. So if we could create a patient task force where they come together and talk about services, whether it's interpreting services or other services within our healthcare system, that would be another way of getting some feedback from patients.
That's a really good idea. Mm-hmm. Yeah. So back to number 2, we were talking about preparing staff to work with interpreters and what's the best way to really get them to immerse themselves in the language access services realm. And we have a question that popped up that would like to know about the training and just ideas. How can we ensure that it's engaging and practical for the staff? Obviously, medical personnel are overworked. We know this, and it's bound to get worse. What can we do to ensure that they are, engaged with the training, they're getting the information, they're really taking it in, but it's not overwhelming their plate. They're not overwhelmed.
That's a good question. I think it really just depends. You can either begin thinking about training as a huge organization, just as an organization as a whole, or just myself, like as a director, for my staff and my unit. There's so much talk now about AI and use of avatar and role, and there's various innovative ways. I don't think there's one way. I think you need to know your organization's culture. I don't think you should rely solely on the onboarding. This is the policy, here are the rules, and then you're done and you check it off. Many of the things that we're tasked with at a healthcare system or as a nurse or a medical provider I always view it kind of on a Ferris wheel. You're going to have to hit these same exact topics, whether it's interpretation, language access, how to avoid a collapse of your body, constantly throughout the year, right? So it's almost on a quarterly basis. There are certain things you need to constantly repeat. And I think that's just kind of what it is. You need to offer it. Some people are very visual. Some people do like hands-on. Some people are fine just reading a PowerPoint. Some people want that interactive with the avatar. I think you need to decide what your culture and your organization is willing to do and then implement. And, of course, cost is obviously an issue, but some of these aren't very costly. But I think it's really just remembering that it's a constant. You have turnover and attrition, just natural. And so just because they were taught, 6 months ago, or you did it that year, you're going to have to keep on repeating it. So this is not a one size fit all. You're going to be able to find people that just are fine with reading it, will know it, their memorization, they are awesome, right? They'll always follow the rules. Then you have those that are like, I need to play with it. I need hands-on. I've never done this before. And then you have those that just would be okay watching a video. I think you need to be able to offer all various ways in order for them to make it engaging and, and practical, really. And I would, for nurses and anybody in the healthcare field, honestly, quick bits. I think 5 to 10 minutes is probably max. If you were to sit them down and ask them to sit down for 30 minutes to an hour on one subject, you're going to lose them. They just,
for sure. Absolutely.
Yeah, I agree. So a couple of other things that you could do. I completely agree. While onboarding, providing information about language access during onboarding is great. It's like drinking through a fire hose. So, you've got so much information that it's, you're not going to retain it all. So I also agree that it's important to make those rounds again and make sure that folks have exposure to how do I contact an interpreter if I need one? What are the ways to access interpreting services? Is it just on the vendor's iPad on wheels, or are there any other methods that I can use in this particular healthcare system? There's also, we haven't talked about, there's attrition, but there's also visiting nurses. So we have nurses that work at many different healthcare systems, and they're, at one system, this is how you get an interpreter services, whereas at another system, this is another way. So we make sure. The other thing I've noticed being on the language access side of things is the easier it is for a clinical team member to reach an interpreter, the more likely they're going to use the interpreter. So we have added the vendor's app to our to the smartphones that all the nurses have in our various hospitals. We will provide training by we also have an in-house call center. I can talk about that. That's one of the things I love about that is we use our vendor's app, and then I have Wellstar. That's the name of my healthcare system. I have team members that work in our call center. So when you dial a Spanish interpreter, you're going to get one of our team members first. That really helps continuity of care. We already know our system. It's disarming when a patient sees someone that they've already seen in person. Now they're seeing them virtually. That kind of gives a little bit of a moment. So other ways we do training are our interpreting team. We go through the census on a daily basis, and we see who is non-English speaking in our hospital. And then regardless of whether we share the same language or not, we also have our vendor's app on our smartphone. So if I go into an Arabic speaking patient's room and want to make sure that the patient know that interpreting service is available to them, I will educate the patient. And then when I'm done, and I take, maybe 2 minutes to let them know we're here for you. Your nurse has access to providing interpreting services. You just let them know that you need one. Then we go to the nurse and let them know interpreting services is here. Remind you that you can get it on your phone, or here's the telephone number if you need to reach, or if you need a document translated, this is how that goes. So we provide a little bit of that education. If a patient's been in the healthcare system for a week or 2 weeks, we might pop in and say hello to them, make sure they're doing well. If their nurse is a different nurse than they had yesterday, we'll do the education again. If it's the same nurse, we won't necessarily take up their time. So we do re-education that way. If the nurses are too busy to talk to us, we might go to the charge nurse and say, hey, at next huddle, would you please just remind your team that we have interpreting services available? So there's a number of different ways that we can provide that education, and then also, the last point I'll make is whenever there's an adverse event in our healthcare system, that information gets, I'm on the list of leadership that gets that report. And what I tend to do is send an email out to the lead of whatever department the adverse event occurred in. And it could be, it's not necessarily something catastrophic. It could be something like, sometimes names, even the patients, we thought we were working with patient A when really it was patient B because, they didn't use both last names or something like that. So nothing bad happened. It's just, we caught it. But so a lot of times I'll take that opportunity to reach out to that department and say, can I come and do an in-service just for your team? Can I do a refresher? So depending on what reports I get, I may reach out, and that's yet another way to provide education.
I think that's great. Just looking for opportunities where it's applicable, let's have this conversation.
Yeah.
I think that's such a great idea. And I do love the point about, you have the visiting nurses, the PRNs that are coming in and they're filling in the gaps, but they don't necessarily have all the information.
Yeah.
And Zoraida, can you say a little bit about what you guys would do with specifically those PRNs, or new hires, PRNs? Let's stick to the PRNs.
Sure.
To make sure they know how to access the services.
Well, let's see. So currently in the organization I work for, I'm not happy, I guess, maybe not the right word, but honored to say we actually don't use travel nurses from outside the organization. So we have an internal network flow pool. And so that really helps because they're expected, just like my staff, right? Because they're part of the organization. They know all the policies. It's the same at all 5 campuses. So that doesn't change. So very lucky that way. And in many other ways, right? Because that is a big hurdle. Not even just language, obviously for all other policies, right?
Yep.
In other organizations I have worked, again, it's part of their onboarding, but then also it's just really making sure that you have that information readily available. Your charge nurses are really your key to that. To making sure that if you do have travel nurses and they are taking care of a patient that is, of another language or deaf or, needing interpretation, that you are aware and that they're aware of how to get that interpreter. Typically, honestly, in years past, I've been on and off of leadership, I've been a charge nurse myself. If we're getting a float nurse, like if we actually had a traveler, we would probably most likely not assign that patient to that traveler. Because again, we want to provide consistency, right? And we want to make sure that the care and the interpreter services is not interrupted. So typically you would not, but that's not an excuse. It's not always possible, but it's really going to be your charge nurse or your supervisor that's going to ensure that traveling nurse knows how to access the interpreters at your organization.
That makes perfect sense, though, to just kind of avoid that issue altogether.
Yeah.
Thank you so much, ladies. Oh, okay. Go ahead,
Deb. One more brief point.
Please.
If you can empower your interpreting team to provide that education as well, not everybody is comfortable doing it, and it doesn't have to be detailed. But if an interpreter happens to, they're the boots on the ground. So just like the charge nurse would empower their floor nurses to provide education to an MA, maybe to a certain level, I like to empower our interpreters to do the same thing, provide some education where you think it's appropriate, or if you're not comfortable doing that, come back to me and let me know where you think there might be a gap or an opportunity for improvement, and then I can take it from there.
Yeah, absolutely. Excellent. Very good point. Okay, so we're going to move on to the next question. The third question is specifically related to the deaf and hard of hearing community. How can healthcare providers ensure that deaf and hard of hearing patients receive the same quality of care as hearing patients? And before you answer, we also have several questions in the chat that pertain specifically to working with deaf and hard of hearing patients. So once we get some feedback from you about that, I'll go and pull some of those out and share those with you as well. Go ahead.
Zoraida, do you want to start or you want me to?
Sure, I can start. The hard of hearing probably a little bit easier than deaf, so I'll go that route first. So we have many, it's not uncommon, I should say, for us to have hard of hearing. We have a lot of elderly patients who just due to the fact of their age and their medical history have hard of hearing. We always make sure and ask about their, hearing devices. Many of them don't like to leave their hearing aids in the hospitals just because they're very costly. And they're afraid they're going to lose them. So we do have amplifiers, or some of them are okay leaving one in. So it kind of depends on which product they have. And I've had some very savvy elderly patients who have like amazing hearing aids, and they're Bluetooth connected to their phone, and it's like amazing. They teach me so much. So we just ensure that they're always, in their ear. And obviously at each change of shift, make sure that that's still with them, right? And if they've gone to a procedure, it's one of those key things like hearing aids in left ear or in right ear or both, right? Then if they don't want to leave their hearing aids in, which I've had many patients say, I don't want to lose them. And last time I was in the hospital, I did lose them. And so we have amplifiers, and they do like that. We can tell then just because they're like headphones. And so we know, and that's kind of an automatic cue for the staff. And so the staff is pretty well versed in making sure that they do understand them and get in front of them and they nod and they are able to hear them. So that has helped in some cases. And then for our deaf speaking patients, we do default then to the virtual iPad. We don't have available all the time in person, sign language interpreters. So that is a cue for us that patient is deaf because that will remain in the room with them.
Thank you so much for mentioning that, Zoraida, because we have one of the questions from Sarah Baker specifically asks about a plan for deafblind patients. So maybe they're unable to access a screen like VRI. And it could be that they're deafblind. It could be they're elderly and it's not working for them. What are the options for those patients? Either one of you guys, whoever will toss up.
I'll take this one. Sure. Hi, Sarah. So I think where healthcare systems get stuck behind the 8 ball is when they only use VRI and they don't have a plan in place to access in-person interpreters when needed. There definitely is a shortage of sign language interpreters that is nationwide. So it's really impossible to provide in-person interpreting services 24/7
Right.
For sign language. We all are very well aware of that, not to mention that it's very costly to do so. That said, you can't just provide VRI, video remote interpreting, and expect that it's going to be okay for everybody. Whether you speak another language or whether it's a patient who is deaf and has other communication limitations, like cognitive limitations, for example, or a patient who's deafblind. So it's important for a healthcare system to know who their local interpreting agency is and have an active contract with them, and also be aware of what to inform the vendor that you're using. Let the vendor know that the patient you don't just need a sign language interpreter. Why do you need one? The patient is deafblind, or the patient is even a pediatric patient. There are some interpreters that do much better with pediatric patients than other interpreters. Another question to ask your vendor is whether or not they work with certified deaf interpreters. Mm-hmm. In healthcare interpreting for sign language interpreters, most states require that that the interpreter has certification. I would advise that for deaf interpreters also. However, there's a lot of limitations when it comes, and there's been some issues with the Registry of Interpreters for the Deaf being able to get people certified as quickly as we would like. So if you have access to a deaf interpreter who is not certified, some questions you would want to ask your vendor are, what is their experience in healthcare? And see if you can get some references and things like that. But being able to get certified deaf interpreters and in-person interpreters have a plan in place to make sure you can do that. That will be very helpful with deafblind patients. There's also a newer form of communication that a lot of deafblind patients use called protactile sign language. Or protactile language. And so that would be another question for the vendor. Do you have any interpreters that you contract with or that are on your staff that are familiar with protactile as well? And so having those, being proactive, so when your deafblind patient walks into your healthcare system, you're not having to be reactive. You already have this plan in place.
Absolutely. So we also have a question that ties again back into working with deaf or deafblind patients. So when they come in and you're working with them, especially deafblind, to figure out what their ideal or preferred mode of communication is, how are you capturing that? Do you have a place for it where the nurse that's coming in later, maybe 3 shifts from now, somehow that gets lost in the translation from, the debriefing that happens. How are you, is there somewhere else that this is being documented, maybe a spreadsheet or somewhere in their EHR? What is that? What do you got? Any solutions there or suggestions?
So in sorry, Zoraida, do you want to go first?
No, I think I was just going to ask a clarifying. So are they asking for tracking, or are they asking for while the patient is there? Are they just asking, like, how do we ensure that everybody knows
that one,
if this patient is a deaf patient
Yep.
needs an interpreter? Okay.
That one.
So, I mean, really, during handoff, which is your SBAR and your bedside report,
Yeah.
the nurses are, and the expectation is that you are going into the room, right? You have a whiteboard. Some places use an electronic whiteboard, which takes information directly from the EMR, which is beautiful, and it's there. But if you're still old school and you're doing it on a regular whiteboard that you are updating, the preferred language is in there, and that information is in there. And that's the information that's reviewed at change of shift during handoff, right? So it's your situation, your background assessment. And so the nurses are trained to go through that. And obviously, if somebody is requiring an interpreter or somebody is deaf or hard of hearing, that information is on the whiteboard. It's in the patient's room, and that is discussed during handoff. Our providers, I work with an amazing group of hospitalists that actually they're just super collaborative, and they really look to that whiteboard. And they're excellent because they provide me feedback. If I know in real time, like, hey, that wasn't updated, I didn't know, they like to see their names on there as well. And so we do that. So this has been a long-term struggle, I think, for many healthcare organizations. How do you ensure that that same information is handed off, time and time again? Yeah. And again, the literature does support, and it's been provided that if you really do your handoff and you use the whiteboard as expected, meaning that it's for the patient, that information is going to be there. And that vital information is, how do they, translate? What's the language they speak? And so that's how we would ensure. There was part of that question was, how do you prevent staff from saying, we only use iPads? And, that is again, a culture and a teaching and something that's on that Ferris wheel, right? It's part of how you train and teach your staff when it comes to communicating with patients and your coworkers. It's no different than when your staff says, we're just really busy, we're short-staffed, because they feel bad that they've had their patient wait a little bit, right? When in reality, you're not short-staffed. It's okay that it took you a little bit longer. Like, just explain that and understand and let them know that it wasn't because you were, sipping a latte. It's, I apologize, I was caught up in another patient's room, but I'm here now, and how can I help you and address your needs, right? It's helping them and giving them scripting that feels right to them, and not that they feel like bad because they did, have a delay or didn't know. So
awesome.
That's usually what I find.
Thank you, Zoraida. Debbie, anything to add?
Yeah, so we recently added, we use Epic, and on the left side of a patient's chart is the storyboard, and in the storyboard you see who is who the clinical team is assigned to that patient. So we recently had our interpreters added to that clinical team. So the interpreter, when they start their shift, can type their name in and be added. So that way clinical team members can know how to contact the interpreter quickly. So that's really helpful, especially if you happen to have ASL interpreters on staff. That's really helpful for our deaf and hard of hearing patients. The other, a couple of other things that are that we do is we schedule our outpatient appointments, ambulatory appointments. We have whichever department does that. It would be helpful to educate them if it's a central scheduling department. For us, we happen to do scheduling for interpreting services. Any patient that needs an interpreter, the request is sent to my department. And then we can make notes in our interpreter management scheduling system that this person prefers a CDI or prefers not to have a CDI, or, this patient prefers more of a signed English communication versus a straight ASL. So there are some places that you can make notes there. I think in the EMR, you can also do FYI tags and things like that. The problem with FYI tags is that you can put an FYI tag in for everything, and it can get to be much, and people will ignore it. So if you can find a consistent way to document the communication needs of that patient, whatever works best in your healthcare system, like Zoraida was saying, it really depends on the culture of your system. But find a way to do it, be consistent with it, and then educate clinical team members on how to follow through with that.
Yeah.
I love that. Yes, absolutely. Okay, so we are running out of time. We've got about 10 minutes left, and I still have a couple questions to go. So what I'm going to say is I'm going to ask one more question. And audience, if you have any other questions, get them in that chat right now, because I'm going to pick a few right before the end so that we can answer them. And actually, I'm going to skip question 4, please. Thank you. Okay, the last question is with recent shifts in immigration policies, how do you see the changes affecting the demand for interpretation services in healthcare? So some of the things we've been talking about, we've been having, internal meetings with subject matter experts to kind of talk about what they're seeing, what they're experiencing on the ground, boots on the ground. What are you getting from your patients? What are you seeing as far as coming down from the top, changes to expect? What are you anticipating, if anything? A lot we've heard is business as usual. So what are you guys seeing?
Sure. I think I'll go first if you don't mind, Debbie. I know you have a little bit more probably to say on this than I do.
No problem. Yeah.
I'm really proud to say that the current organization I work for, there has not been a change. They didn't shift. They didn't decrease the availability. They didn't change their policy. Again, they kept the patient at the center. So I was very proud of that. So I have not seen a change when it comes from the top down, except for reinforcing of we provide care, and the care that our patients need, we will provide them, right? I have not seen a shift in patients requesting or needing. So that's positive. I do worry though that maybe some will, and I don't know how I would ever actually see this. I can see that this may delay care for many out there in the community. Yeah. And I think unfortunately we won't see that until later, right? The data won't show that until later, as we all know that. But currently, as of right now, I have not seen a change from our organization as far as providing, and I have not seen a change in the way we request or handle our requests or our interpreter services in the organization I work for.
I'm so glad to hear that. I can imagine you're very proud.
Yes.
Definitely, it's something that, from my perspective, from what we're seeing, and is the fear that patients aren't going to be safe, or they're going to be identified, when they get to the hospital. Not necessarily that they're going to call ICE right away, but what if ICE shows up and they're there and they need help? And so they, like you said, Zoraida, they're delaying their care until it becomes an emergency. Right. And then they're coming in and there's all, so much more to deal with than if they would have just come and had it taken care of. But again, there's fear there. There's a lot of, maybe it's more of a misunderstanding that's not making it down to those patients. We know from our conversations, the three of us, we've had them, that we're still business as usual. Yes, things are changing, may not change, but those end users, they are seeing a lot of fear. They're receiving a lot of fear. And, so Debbie, please.
Sure.
You have to say as well.
Yeah. So, first of all, most healthcare systems, they have already put out a statement about, what to do if ICE shows up at your system, because healthcare systems are no longer the safe space that they used to be. So that's part of what's causing the fear and why patients are hesitating to come and get care when they need it. So educating if you have staff interpreters, ensuring that have a team meeting with your staff interpreters and let them know, because they're the front line. They're going to be talking with the patients. So letting them know that this is how your healthcare system is handling that. This has been passed down from security to frontline team members. This is, should anyone, whether it be someone from ICE or, or a patient's family member who is making a big fuss and shouldn't be on property, how do we handle that? And that should be handled consistently. So again, consistency is key here. So making sure that your team members have the information they need to make decisions on the spot is super important. The laws, so there is a lot of misunderstanding, especially now that this executive order calling English the official language of the United States. So while that is an executive order, it is not a law, and it does not supersede or it doesn't remove any of the laws that are currently in place. The Title VI of the Civil Rights Act from 1964 is not going away. The Affordable Care Act is not going away. Mm-hmm. There may be some slight modifications in it, but it's not going away. The Americans with Disabilities Act is not going away. There are all these laws that are in place, federal laws, CMS standards, Joint Commission standards, that require us to provide effective care to our patients and effective communication. Those things are not going away, no matter how the landscape changes, no matter what administration is in place. So we still have the obligation to provide language access services, including translated documents. Now, which documents, of course, the minimum standard is vital documents, but in addition to that, what other documents does your healthcare system plan on being translated? Those are conversations to be had. But we are still obligated to provide services to our patients in their preferred language to ensure they understand how to take care of themselves and that they have access to their healthcare information. So it's not that the landscape is changing, because I don't think it is. I think that there's a lot of fear that's being put in, that's being put out there, and that's being interpreted in different ways. So reassuring your staff and making sure that people understand that these laws are still in place is really important.
Another quick follow-up question, Zoraida, I'm going to give you an opportunity to answer as well, but question that just popped up: is ICE above medical facilities? Meaning, can ICE come into a medical facility, you say, stop, you can't be here, or you're not allowed to, whatever, and they have to listen? Or are they able to say, we're going to arrest you and go into a patient room, for example?
So so first of all, let me just preface anything that I say by saying I am not an attorney.
Of course. Yes.
I'm not an immigration attorney. I'm not. So I would definitely advise you to reach out to your legal and compliance departments to determine what applies in your healthcare system. I can tell you that ICE does not supersede HIPAA. So, they may be allowed in the facility, but are they going to be allowed in a patient room and be allowed to question a patient while they're getting care? Not in my healthcare system. HIPAA is still a thing, and we're not obligated to let you know that someone's here. I would defer to legal and compliance for what works in your healthcare system. Zoraida, have you, hopefully you've not encountered this yet, but what's your thought on it?
Yeah, luckily I have not. However, I would echo exactly what you said. I'm not the expert. If this ever was encountered in our facility, we would absolutely, the same consistent process, right? Just as if another federal agency was to come in, we would contact our legal, right, department and security. Those are our key two people in our executive team to know and take their direction. And it would be the same consistent process. But again, I echo what Debbie said. ICE does not supersede HIPAA. Some of these other laws that are there to protect your patient, the Patient Rights Act, those are still there. But we would do the same thing.
And we still have the obligation, to do no harm. And so protecting patient safety is part of what we as not just employees, but also your contractors. So if you have an interpreter who's a contractor, they are an extension of the healthcare system. So they also are obligated to report to, a charge nurse or to reach out to not only, I would say not only the charge nurse, but also the interpreting agency that they were sent from. And that way leadership from both organizations can talk with each other.
Definitely. That's a very good point. Zoraida, anything to add?
No, I would completely agree with that.
Okay, guys, that puts us at time. If there's not anything else, Debbie or Zoraida, that you'd like to add just in general, we'll wrap this up.
No, just thank you. I appreciate the opportunity. I love the questions, and I personally have learned a lot. So thank you for that.
Awesome.
And maybe we can do this again.
I hope so. Thank you guys so much for being here. It's been great to hear both of your perspectives, like Debbie pointed out in the beginning, or maybe it was Zoraida that pointed it out. Just those two separate perspectives are so important to have in this conversation. So thank you so much for being here.
Absolutely. Thanks for inviting me.
Yep.
All right, guys. Thank you. Thank you, audience, for your attendance. And we will see you next time.
Have a great day.
Bye.